Coming to ACLS and BCLS. Now, ACLS is Advanced Cardiac Life Support, whereas BCLS is Basic Life Support. Now, Advanced Cardiac Life Support, as the name says, is an advanced course, whereas Basic Life Support is a basic course. So, what does it mean? Basically, it means that Basic Life course is something which even a layman can learn and help save a person in cardiac arrest, whereas ACLS is something where a medical professional is required, at least somebody with a background of medical knowledge and pharmaceutical knowledge for the medications which are required. Now, as far as coming to the procedures, I will teach both of them here. Now, first thing when a patient has a cardiac arrest is immediate recognition of the cardiac arrest. Suppose the patient has chest pain, falls unconscious, has breathlessness, and then we have to have the activation of the emergency response system. In this emergency response system, early CPR with emphasis on chest compression is very important. Now, rapid defibrillation is the second more important thing. Effective advanced life support is the third thing, and integrated post cardiac arrest care is the fourth thing. I will teach each of them here. So CPR stands for cardiopulmonary resuscitation. Now, a simplified adult basic life support is when a patient is unresponsive or there's no breathing or abnormal breathing, he's gasping, then activate emergency code. Basically, we will know what to do in emergency code. Emergency code is something known as code blue, where a patient if we activate that, it starts a set of protocols in a hospital or in an airport or in a railway station where there are people dedicated for advanced cardiac life support who can come over and take over from you once you finish the basic life support. Now, once the activated emergency code is activated, basically what we need to do is to get the defibrillator and start the CPR at the same time. Push hard, push fast in a cyclical manner. Now, check rhythm of the patient and shock if indicated. Repeat every 2 minutes. And push hard and push fast. These are the important steps. Now, as we can see that here in this airport, we have this advanced AED, that is the electric defibrillator, and here also we have it here. Okay, so basically these defibrillators are emergency defibrillators, are kept everywhere in major places of where people are, so that if somebody goes into cardiac arrest, you know what to do. Now, the full form of AED is automated external defibrillator. Now, early defibrillation with an AED. First thing is turn the machine on, turn the AED on. There will be a red button somewhere here and you can turn it on depending on the type of model which you have, but it will be pretty prominent so that anybody who is not even well versed with the machine can start it on. Now follow the AED prompts. Generally these are written here on the box, inner cover of the box, and resume chest compression immediately after the shock. Now, this graph shows that the more time you waste after a person goes into shock and defibrillation, less is the chance of success of survival of that patient. So try to shock early, try to shock fast, and that's what is important. Now, use of the AED. First, push the button to release the lid and turn on the defibrillator. Pull the handle to get the electrode pads, which you probably would have seen in plenty of movies and you would have some idea about it. Otherwise, pretty much details are given in the inner box cover and also sometimes on the electrode. And then the electrode itself will show where to place the pad. So you place the pad exactly where it's shown on the electrode on the patient, and then you press this flashing button if told to do so, and that gives a shock to prevent defibrillation to stop the defibrillation of the heart. Now this is a picture which shows the same thing, and this shows the placement of the electrodes. And once you do the shocking, please remember that when you are doing the shocking, you should keep your arms and your body away from the patient, otherwise you also will get a shock. Now after this, ask for help and then start the CPR again. Now, what is a high quality CPR? A high quality CPR is basically start compression within 10 seconds of recognition of cardiac arrest, push hard, push fast, at least 100 chest compressions per minute, at least 2 inches or 5 centimeters of depth, per compression of the chest. That is, when you put your hands and press, the chest should go down by at least 2 centimeters from its baseline level. Allow complete chest recoil after each compression. Do not keep pressing the chest continuously. Minimize interruptions in compression to less than 10 seconds. Give effective breaths, that is visible chest rise. That is, you have to give a mouth-to-mouth resuscitation, and it should not be just a mouth-to-mouth, but the air should flow from your lungs to his lungs or her lungs, and then there should be a visible chest rise, and that is an indication that air is actually moving into his lungs. Avoid excessive ventilation. So this is a picture showing the chest compression. Now, again, to summarize, basically, this is a slightly more detailed chart where it shows that if a patient is unresponsive, acute emergency response system, get the defibrillator, check pulse, definite pulse within 10 seconds. If there's a definite pulse, give one breath every 5 to 6 seconds, recheck pulse every 2 minutes. If there's no pulse, begin cycles of 30 compressions and 2 breaths, that is 30:2 in, and that should be at least 100 compressions in a minute. That means at least 3 cycles of 30:2, and then start the defibrillator and then shock the patient. If he's shockable, give 1 shock and resume CPR. If he's not shockable, then continue to do CPR. I'll tell you what is shockable rhythm and non-shockable rhythm very soon in the slides. And then the goals of resuscitation are to support and restore effective oxygenation, ventilation, and circulation, with return of intact neurological function. The brain should not get damaged. That is very important. And then ROSC, that is return of spontaneous circulation, is an intermediate goal. Now, the ACLS survey shows that the steps are airway, breathing, circulation, and a differential diagnosis. The first and foremost is airway. Now, a lot of modifications have been done where they say do the circulation first, do the breathing first, but still this holds pretty much good universally, where you try to secure the airway first, then initiate breathing for him, and then look at his circulation and try to find out the cause of that, of his unconsciousness or breathlessness. Now, airway. Is the airway patent? Is an advanced airway indicated? Is proper placement of airway device confirmed? Is the tube secured and placement confirmed frequently? These are the questions which you need to answer once you observe the patient and look at his airway. Airway, by airway I mean his trachea. Now, technique of airway management and ventilation is open the airway. To open the airway, you do a head tilt and chin lift. You make the patient lie down and give him a hyperextension, a slight extension in his neck, so that the head gets tilted upwards and there's a slight chin lift. And then a jaw thrust forward so that his mouth opens, and make sure his tongue does not fall backwards. Now, ventilation, otherwise he will not be able to breathe. Now, ventilation is either mouth to mask ventilation, but it's better if you have a bag mask ventilation, because then you can do a manual ventilation, and chances of transmitting diseases to each other through mouth to mouth ventilation is much more than a bag mask ventilation. So this is a mask holding technique. As you can see in this patient, that his head is down, and we have given a slight extension in his neck, a little bit of head tilt, and we have put our fingers below the chin for a chin lift, and then we have placed the bag mask over his mouth after opening his mouth. And then there comes the advanced airway. That is, if we are not able to do any breathing, if his chest is not rising with the bag and mask ventilation, then we have to do a laryngeal mask airway or a Combitube or an endotracheal intubation. Now, in basic life support, we do not need to learn all these, but in advanced life support, you should know how to put a laryngeal mask airway, Combitube, and endotracheal intubation. Now, since I'm trying to be more specific on basic life support, because that's something which all of us should know, I will just quickly go through it. That this is a Combitube, which is like a large tube where there's a balloon and there's lumen, and these are put in the mouth of the patient, and these are techniques which have to learn practically if you do an ACLS course. And then after you put in the mouth of the patient, you have to inflate the balloon, so that to prevent it from moving inwards or outwards, and also to prevent any gastric stomach contents to vomit back into the trachea. And after this is done, we have to attach the bag to it and give bag to mask ventilation. back to the tube ventilation. Now coming to breathing, now once you start ventilation, is his lungs getting any oxygenation, and is he able to breathe on its own? Are ventilation and oxygenation adequate? That can be monitored by a pulse oximeter machine, which helps in telling us the amount of oxygenation he has. Our quantitative waveform capnography and oxyhemoglobin saturation monitored, as I said before, that can be done easily with a pulse oximeter. And waveform capnography is a more advanced technique and not possibly available, not available everywhere, but a pulse oximeter will be more than sufficient. Now coming to circulation of blood, and that is very important. Now the chest compressions are basically to maintain the circulation, so that the heart gets enough amount of blood and does not go into total cardiorespiratory failure. Now what is the cardiac rhythm? Is defibrillation or cardioversion indicated? Has an intravenous access been obtained to rush in fluids, normal saline and ringer lactate to maintain the circulation if the patient has lost blood or is in shock? Now, is resuscitation of the circulation present? Is the patient with a pulse unstable? Are medications needed for the rhythm to maintain BP? I will tell the basic medications also in this slides. Now, does the patient need volume or fluid for resuscitation? These are the things which need to be taken into account once we are assessing the circulation of the patient. And lastly, A, B, C, D. The D is differential diagnosis, to know what exactly caused the symptoms and whether it's a reversible cause or a non-reversible cause. Now, this is slightly on a higher level. I'll say the advanced cardiac life support, that where we start CPR and then we assess, and if there's a ventricular fibrillation or ventricular tachycardia based on the monitoring ECG which comes out in the fibrillator or is shown in real time on its monitor, then we can do a CPR, and then rhythm is shockable. Yes, then we shock, give epinephrine every 3 to 5 minutes, consider advanced airway capnography, and the rhythm is shockable again, then give another shock and give amiodarone, and the shock should be, after the shock, the CPR should be maintained for 2 minutes each. Now, if these rhythms are non-shockable, then if no signs of return of circulation, spontaneous, go to 10 or 11. That is basically, if it's it's a non-shockable rhythm, that is, give CPR, give epinephrine every 3 to 5 minutes, and again, if the rhythm is not shockable, then give CPR for every 2 minutes, after every 2 minutes, and treat reversible causes. So these are the things which we need to know. Now, this is basically a picture of a normal sinus rhythm, where we can see the P wave and then the QRS complex, again a P wave. We can see that there's equal distance between the tall waves. Whereas look at this picture, there's so much irregularity, and some are short, some are long, and this is the patient has gone into ventricular tachycardia, and this is how the picture of an ECG of a ventricular tachycardia looks. Look at this. This part is looking exactly like this part, and so that is a patient with ventricular tachycardia. Now, coming to, again, this is another rhythm where the patient has gone into arrhythmias and into ventricular fibrillation, where there's absolutely no well-defined rhythm, and this is also again a case where we can shock the patient, and so ventricular tachycardia and ventricular fibrillation are shockable rhythms. Now, if there is asystole, there's no rhythm, it's like a straight line, then there is no point of shocking that patient. Now, this is a defibrillator, an advanced one, and you can see that we can easily see on the monitor the rhythm of the patient, and we can compare it also with a normal rhythm, and then we can shock the patient as shown in this picture. Once again, keep your body away from the patient once you're shocking the patient, because you might also get a shock. Now, medications. Now, medications are first of all, assess or give an IV access, because you need to give the medication through intravenous access and not through the mouth, because then the patient can aspirate and go into the medication can go into his lungs and make things worse. Now, interventions not routinely recommended and basically part of the advanced cardiac life support are atropine, soda bicarb, and IV fluids, calcium, and pacing. So these are the things which are required. Now, endotracheally also the drugs can be given through the tracheal tube. These are lidocaine, epinephrine, atropine, naloxone, and vasopressin. And the adult immediate post-cardiac arrest care is basically after there is a return of spontaneous circulation, optimize the ventilation and oxygenation so that the saturation on pulse oximetry shows more than 94%. Consider advanced airway and wave nerve camptonectomy. Do not hyperventilate the patient because that can cause much more lung injury than what happened due to the shock. Now treat the hypotension of the patient if the BP is less than 90. Give vasopressin infusion and 12-lead ECG. And if the patient has follow the commands. If the patient has a myocardial infarction, then that's basically the patient has a heart arrest, a cardiac arrest, then advanced critical care is required, which is beyond the limits of this course because that becomes a bit for the very advanced medical professionals who have dedicated years of training in emergency medicine. And if you have done this much, I think you have done enough for the patient and let the professionals take over. One thing about is maternal cardiac arrest. If you see a pregnant woman and who has gone into cardiac arrest, first responders should activate the maternal cardiac arrest team. They should shout for help and try to get the team which is has a maternal cardiac arrest protocol along with it, and document time of onset of maternal cardiac arrest. Place the patient in the supine, that is the lying down position. Start chest compression just as the basic life support algorithm of 30 chest compression followed by 2 breaths and 3 cycles of this in a 1 minute time duration. And subsequent responders should treat the as per ACLS and BCLS algorithms and all obstetric interventions, that is left uterine displacement. This is a picture which shows that they try to push the uterus to the left hand side because the uterus then unnecessarily presses on the aorta, which is the main supply of blood vessel of the body, and if you push it out from that place, and then it will not cause decreased circulation. Now if no resuscitation by 4 minutes, then consider performing immediate emergency cesarean section. Aim for delivery within 5 minutes of onset of resuscitation efforts, otherwise we will lose the child. Now these are very advanced things, but basically what we need to do as a basic layman person, if you see a pregnant woman gone into cardiac arrest, make her lie down, try to push her uterus on the left side, okay, as shown in this picture. If you can tilt the bed so that it automatically gets lifted to one side, that's fine, and then start chest compression as you see in this picture, and make sure you shout for help and call for the emergency resuscitation team. Those are the things which we can do as a layman to help a patient who has gone into cardiac arrest. Rest the medical professional team can take over, and it takes actually years of training to be a medical emergency medicine professional. Thank you.